So adjuvant treatment for urothelial cancer, for muscle-invasive urothelial cancer, has been challenging over the years. It took several decades of studies exploring adjuvant chemotherapy to show that adjuvant chemotherapy may be helpful, although we really didn't have definitive data for adjuvant chemotherapy. And then the next generation of studies came with adjuvant immune checkpoint blockade. And we have 3 randomized phase 3 studies testing whether or not we should give adjuvant PD-1 or PD-L1 blockade after surgery in patients with muscle-invasive urothelial cancer at high risk for recurrence. We have IMvigor10, CheckMate 274, and the Ambassador study. Of those studies, the Ambassador study and CheckMate 274 demonstrated an improvement in disease-free survival with adjuvant PD-1 blockade versus either observation or placebo. In the IMvigor10 study, adjuvant atezolizumab did not show a benefit. So lots of progress made, 3 completed phase 3 studies showing similar but not the same results. In the CheckMate 274 study, disease-free survival is the primary endpoint, and that's both in patients in the all-comer population and in patients with tumors with high PD-L1 expression. So co-primary endpoints for disease-free survival. Overall survival is a secondary endpoint. It's an event-driven analysis, and it's tested using a statistical hierarchical design. And so interim analyses for overall survival have been performed. Those results did not meet the predefined threshold for statistical significance. Those results were shown for the first time at the EAU meeting and demonstrated a favorable overall survival for patients receiving adjuvant nivolumab versus placebo in both the all-comer population and in patients with tumors with high PD-L1 expression. So after a patient has undergone radical surgery for muscle-invasive urothelial cancer, particularly bladder cancer, this is a major operation. And so I think we have to think very carefully about the treatment burden that we impose on patients after undergoing that operation. Some of these patients have already received chemotherapy as well. So that's a lot of treatment burden. We have to be quite thoughtful about that. Thankfully, immune checkpoint blockade in many, many patients is very well tolerated, and that's why it's been conducive to explore in the adjuvant setting even after patients had previously received chemotherapy and undergone radical surgery. But it's not without its downside. On the CheckMate 274 study, there was a grade 3 or higher treatment-related adverse event rate of 18%. So 18% of patients are having side effects that are not insignificant, and I think we have to be very thoughtful about that. For immune-related side effects in particular, it's about early reporting and recognition. So immune checkpoint blockade-related adverse events can mimic lots of other things. Patients have diarrhea, they have a rash, they feel incredibly tired, related to colitis, related to dermatitis, related to adrenal insufficiency. Those symptoms can be difficult to detect as they can be difficult for patients to attribute to their treatment, and sometimes for other doctors to attribute to their treatment because they're not used to seeing patients on these treatments. So it's about educating patients what to look out for and to instruct them to report any changes in their health to their oncologists, because any change in their health potentially could be linked to an immune checkpoint blockade related side effect. So I think there are probably 2 major categories. The first category is how we can exploit other cellular subsets that contribute to anti-tumor immunity. We know that myeloid cells play a key role in either inhibiting or or assisting an anti-tumor immune response, but we don't know how to modulate myeloid cells, dendritic cells, or macrophages. And we know that NK cells could be critical to anti-tumor immunity, but we have no treatments that exploit NK cells yet. So I think there are a number of interesting targets that are being explored in the clinic that will hopefully make an impact. I think on the flip side, even though we had many advances in urothelial cancer in the past several years in terms of systemic treatment, most of those treatments are not based on cancer cell intrinsic biology. They're related to modulating the tumor microenvironment. And we still have very few treatments that are specifically trying to exploit what we know about bladder cancer biology itself to try and improve disease outcomes. And I think we're going to see some of those treatments coming as well, not only recurrent mutations, but actually targeting transcription factors that might play a critical role in bladder cancer biology.